everyone. This is a content clinic for nursing 421, and this is the information regarding vigilance and all things shock and then mods. This is information that is going to be on exam 2 in 421's course information. So this week, you and your instructors have the opportunity to discuss all things shock and mods. I'm hoping to go through and help clarify some information for you. Today is an opportunity for us, so please let me know if there's anything that you have questions or anything at all. Our objective for today is to recognize the clinical manifestations, the etiology, the pathophysiology, medical treatment, and the nursing care of patients who are in shock state, including a sepsis continuum from SIRS to septic shock. And I'll clarify that, and we'll talk more about that in just a minute. So first, let's talk about shock. Shock is when you have a hypoperfusion, meaning you do not have enough blood perfusing to all of the periphery. This results in a hypercoagulability. That also results in an activation of your inflammatory response system. So, when we think about it being hypoperfused, you must recognize that the blood is not getting the nutrients and the oxygen that it's supposed to have to the tissues who actually need it. Now, when this happens, our cells convert from an aerobic to an anaerobic metabolism. Now remember, we are creatures who like air, and our cells are too. But when they convert to anaerobic metabolism, this actually changes the makeup and the balance of pH balance. Please remember that, again, we've said this numerous times, but if oxygen is not meeting the demand, in other words, we have an insufficient amount meeting the cellular demand, wherever we don't get oxygen, that area dies. So cell death happens. That's some of the very first death that happens. Now, as more and more cells die because we have an extended period of no oxygen, then we have to think about, okay, if enough cells die, now we have tissue death. And that can progress to we have enough tissue death, so now we have organ death. And we will actually see that tissue progressively become dysfunctional, and eventually the organ, and then even that organ will progressively malfunction, resulting in an end organ failure. So there's actually 3 stages of shock. The first one is one of the most missed stages of shock. This is where the body actually tries to compensate for the decrease in whatever is causing the shock, either that be the volume, be that cardiac output, or be that some type of vasculature issues. Whatever the cause, the body tries to activate the compensatory mechanisms that it has to take care of that, and it works for a little while. So if we have a decreased cardiac output, or we have a decreased circulation, or we have a decreased blood pressure, the body will automatically do some things. That is, increase the heart rate. It will try to increase preload, and you have arterial vasoconstriction, raising your SVR. So therefore, the body will maintain as normal of vital signs as possible. And the only thing you really are going to see is a slightly elevated heart rate and a slightly elevated respiratory rate due to all the extra work. There is definitely good cerebral perfusion, so there's no changes in mentation. So therefore, that shock state really does not get recognized because the body's actually taking care of it. Now, it can only do that for a very brief period of time because the body fails. That leads us into stage 2. Stage 2 is where that begins to fail. The compensatory mechanisms can only last for a certain amount of time, and then they no longer work. And if you remember in the cardiac material, I talked about how when the body tries to compensate, it actually can make things worse rather than better. Well, the compensation mechanism for shock does exactly that. As this begins to fail, we start getting metabolic and circulatory derangements. They start showing up, becoming more and more pronounced. Then we have an increased inflammatory and immune response. And so this increases the vicious cycle of deterioration, resulting in dysfunction of one or more organ becoming apparent. Well, in other words, we'll be able to see the signs and symptoms of that, where we couldn't see that before. Well, we're supposed to intervene at stage 1. Hard part is we don't always recognize stage 1. So we should intervene at stage 2. Well, if we don't, then the patient moves into stage 3. This is actually the final stage, and it's irreversible. This is where cellular and tissue injury are so severe that the patient's life is not truly sustainable, even if you corrected your metabolic, your circulatory, and your inflammatory differences or derangements. You correct all that, the patient will still not survive. This is where we have resulted in complete shutdown. We have full-blown multi-system organ dysfunction syndrome, where we have multiple organ systems that are failing. And it's all become very evident. So we have to stop this in stage 1 or stage 2, because once they reach stage 3, it's irreversible and our patients do not recover. So one type of shock, because remember there are multiple types of shock. We are going to talk about them. The first type is hypovolemic, which is how much volume you have inside your tank. Okay. Cardiogenic is how good of a pump you have circulating all that volume in your tank. So we refer to our heart as a pump. Then there's something called distributive shock. This is relation to the pipes, or our vasculature system, on where the heart pumps all this volume around the body through, okay? The distributive shock actually comes in 3 subsequent types, and we will get into that in more detail when we reach that. Let's start with hypovolemic shock. Hypovolemia is a result of inadequate circulating blood volume, which causes a sudden blood loss or severe dehydration, okay? But it also can be an injury that actually causes significant fluid shifts from the vascular space into the interstitial space, such as a burn, major burns, and we call that third spacing or edema. You already know how to do an assessment, so I'm not going to go through that with you. You already know that. But please remember, it's important to get the history of these patients because sometimes it will give you some good information. You definitely want to keep monitoring continuously the patient's vital signs. Please monitor that tachycardia and that hypotension. You want to look at your respiratory status because remember, the harder the body works, the more respiratory rate you're going to have. Because the body's working harder, you got to breathe more. Please keep in mind also that if somebody is a habitual taker of NSAIDs, that could be an upper GI bleed. So little flags should be in your head thinking, oh, that could be, that could be. You have to think about those things. So the clinical findings are related to how severe or acute the loss of volume is. So if you find that your blood pressure is just a little bit low, then you have a little bit of a volume loss. If you have a very low blood pressure, then you have a lot of volume loss. You're going to be monitoring serum lactate, which is drawn in a gray top tube, and it is sent to lab on ice. And that's because lactic acid begins to build significantly when we move into the anaerobic metabolism. You're going to want to monitor arterial pH because we're looking for acidosis. You're going to want to monitor serial H&H. Well, that means serial means, of course, that we're going to do it on a routine basis, such as Q6 hours. The H&H, well, if you don't have enough hemoglobin, then there's no way you can carry enough oxygen to the tissue that needs it. So if you have a low hemoglobin, you'll never get enough oxygen. So your H&H has to be normal for you to be able to help correct this. And then, of course, your coags are going to be off. They're going to have problems. Your fibrinogen, your platelets, they're all going to start getting wacky. That's a good word, wacky. So how do we manage these patients? Okay, so because it's volemic shock, you're going to treat this one with volume. But the reality is that any shock is originally treated with volume. You got to save their life before you can do anything else. So, especially with hypovolemia, we are going to administer a lot of volume. Well, in order to get a lot of volume in very quickly, we need to have a very large bore IV because we have to use something called rapid infusion. We want at least a 16, and we prefer a 14. But let me tell you, those are garden hoses. And if you have somebody who's dehydrated and you're trying to put in these big old IVs, it becomes very difficult sometimes. But we need them to be able to get the fluids in as fast as possible. Now, when we give large quantities of volume, it's even at room temperature, it's actually cooler than the body. So we start getting hypothermia effects. And I can tell you there are also negative effects to hypothermia as much as some of the good effects we're able to use when we talk about hypothermia with cardiogenic MI or with cerebral infarct. Okay? One of the fluids that we can use is isotonic crystalloid solution. So isotonic means when we put it into the blood vessel, it stays in the blood vessel, right? It does not diffuse into the cells, and nothing else is sucked into the vasculature. It's isotonic, meaning it doesn't have a high or low salt content. All right? Now, you can give all the fluids that you want, but if you wash that out and you eventually do not give blood, there will be a situation where your hemoglobin will drop. And then you are back where you started. You don't have enough hemoglobin to carry enough oxygen to get where you need to go. And there's a standard of where if you give 3 to 4 liters of fluid, then you should give a unit of blood. And depending on what's going on, if you have coagulation issues, you want to give a unit of platelets and or fresh frozen plasma. Now, one of the other colloids that you can give, a colloid that you can give rather than a crystalloid, is albumin. That's because albumin is what's needed to maintain the cell wall membrane. When it breaks down, increasing permeability, this is where we start getting the leakage of fluid into the interstitial area or third spacing, causing edema. So keeping our cell wall strong with albumin is significant. So if there's any questions on hypovolemic shock, please don't hesitate to reach out. Also, if you're watching this at a later time, do not hesitate to reach out to your faculty. All of us are very happy to help out anytime that you need us. So now I'm going to move on to cardiogenic shock. Okay, so we talked about volume. How full is the tank? Now we have to talk about cardiogenic shock. Is there a problem with the pump? So your car will not go if you do not have gas in it. Well, if you have gas in it and the fuel pump is broken, it still won't go. So I hope to use that analogy to help you better understand. So our pump doesn't work if we have left ventricular weakness due to ischemia or MI. That wall will not work. It loses its contractility, therefore dropping stroke volume, therefore dropping cardiac output. So if the pump doesn't help the volume go, it's not going to go, right? Now, there's a bigger word here, neuroendocrine compensatory mechanism. All that means is your systemic inflammatory response system. That's all that means. This is your fight or flight information. This is where your body says, uh-oh, something's wrong. We got to fix it, or we're going to be in trouble, right? And the way that happens is when cardiogenic shock happens, even a heart failure, your body works at increasing preload so that we get Starling's law, okay? And remember, preload is how much blood is in the ventricle just prior to contraction, right? And so if we get a little extra blood in there, we get a little extra stretch in the hopes that we can get a better rebound of that tissue when it starts to come back together. It does this through the retention of sodium and water. Now, one of the things that happens that actually works in the opposite of what we want is that this system also increases your afterload, which is how much force your heart has to work against to get blood out through the aorta into the arterial system, okay? And it does increase the afterload via your vasoconstriction. That reading is done by SVR. So remember, your SVR tells you what your afterload is. And remember, normal is 800 to 1200 dynes, okay? Now, yes, there's some things that can help us, and then there's some other parts of that inflammatory response or the fight or flight response that are actually hindrances or detrimental. Pretty soon, all of them will actually further impair cardiac output and exacerbating cardiogenic shock, the reduction of cardiac output, the overall problem. So again, we're talking about assessment, and we just finished talking about cardiac assessment. So I'm not going to go through that in detail with you. What I do want you to know is that with the MI, you can have, just within a few hours of that beginning MI symptoms, you can have cardiogenic shock within just a matter of a few hours. It's extremely important that you do vigilant, close monitoring for any progressive hemodynamic compromises and or clinical deterioration of your patient, because that'll be your first sign that your patient is going into its cardiogenic shock. Please remember, your patients will become unstable. That means a systolic blood pressure of less than 90. The difference here is the perfusion state. Anything less than 70 is an abnormal perfusion. Perfusion is anything greater than 70. That's good perfusion. If it's less than 70, it is not normal perfusion. Now, what you remember is the map of less than 65. Now, if you remember correctly, that's where there is no more perfusion to the kidney. Okay? Remember, cardiac output can be indexed with the body surface area of that patient. And when we index it, that means we have individualized the cardiac output for that person. And so if we're going to index the cardiac output, we're going to index it we need to keep it greater than 2.2, right? Now, we talked about the pulmonary artery occlusive pressure, which is the same as your pulmonary capillary wedge pressure, which is the same as your wedge pressure. So please don't let those get you messed up. Remember, we talked about that being like 12 to 18. Well, we're going to try to keep that greater than 18 because, remember, we want that increased preload to help give us that Starling's law stretch. So how do we manage these patients? Well, the first thing we need to do is optimize our cardiac output and our preload, which gives us that left ventricular end-diastolic pressure. Remember, we want it greater than 18, but 14 at least. But we also want to protect and not have as much increased afterload or vasoconstriction for increased SVR. We can give pharmacological agents to actually increase the contractility itself, and Dobutrex or dobutamine is one of those. That directly empowers the strength of the muscular contraction. Now, when people have a driving medication like dobutamine on an area that is ill and weakened, this gives us a higher risk for dysrhythmia. So there's a high possibility you're going to need antidysrhythmics, such as your amiodarone. You may even need to do cardioversion, which is synchronized cardioversion. And you might even need to pace that patient to help restore stable heart rhythms to better provide cardiac output. Because if it's unstable, you're not going to get good consistent cardiac output. We definitely want to watch our potassium, calcium, and magnesium because those minerals and electrolytes, when they become out of balance, they actually contribute to the dysrhythmias. Remember, potassium leads to VTAC, VFib, and then, of course, magnesium leads to a specific kind of VTAC that's called torsade. Calcium actually reduces cardiac muscular activity, period. So we definitely want all of those to stay in the correct range. Now, you heard me say earlier that we want to make sure that the SVR is not increased with vasoconstriction. That means we want to decrease the left ventricular workload. We can do that with pharmacotherapy, such as vasodilators, to reduce the SVR, therefore the left ventricular end-diastolic pressure, or the workload of that left ventricle. One of those is nitroglycerin. Another one is sodium nitroprusside. I will tell you that very small changes in nitroprusside make huge changes in the patient's blood pressure. So when you have them on that, you have to be very careful about how fast you move and that you're continuously monitoring that patient. Now, didn't I talk about dobutamine to strengthen the cardiac contractility? We've got a little extra stretch going with preload, and that's all to get the blood out of the heart, but yet you want me to dilate the vessels. That's because I don't want the heart to work so hard with that weakened left ventricle. So yes, I do. I don't want the vasoconstriction to happen. I don't want the SVR to go up, because if that happens, then the heart has to work even harder, and we don't need that. The patient has enough of that. Now, if you have a patient who has a severe enough case, we actually can do a couple of different things. One of those is an intra-aortic balloon pump. The other is a left ventricular assist device. You may have heard it called LVAD. Now, the intra-aortic balloon pump is the one that we put it up in through the femoral artery, and it sits in the aorta right next to the heart, right at the left ventricular area along the side. We can time that balloon to inflate and deflate appropriately with the patient's heartbeat so that it can help squeeze the blood out as the heart contracts, and it can actually cause a suction vacuum as the heart starts to relax to help blood flow really easy, okay? Now, please remember, this is a short-term treatment. It's not anything long-term. It's short-term. LVADs are much more invasive. We actually have to cut somebody open, and we put an LVAD in, and there's a pack that they wear on the outside. And this is usually only given to people or used with people who need to have transplant, and we use this to help keep them alive until their transplant comes through. So we say that's a bridge to transplant. I will tell you there is research and studies going on now where there are people who are living on BiVADs, and bi means both, a right and a left, ventricular assist devices, and they're living on it. They know that they will not get a heart transplant, and they've opted to participate in these studies. And actually, from what I'm hearing, some of these studies are going very well. Now, when your patient is this sick and the pump isn't working, you're going to have some pulmonary issues that have to be addressed. And one of those is all this acidosis. The body doesn't like it. So mechanical ventilation, intubation and mechanical ventilation may be necessary to correct acidosis and then actually assist in improving oxygen delivery out to the tissues, out to the cell level. Please remember, we're going to talk about SVO2 during this period of time. And what that is just like when you do a blood gas, you get a PaO2. That's your saturation of your arterial blood. You can get something called a mixed venous saturation. It's written like SVO2, saturated venous oxygen. We call it a mixed venous. What you can do is when you get that drawn, they can run a blood gas on it. And that actually tells me how much how much oxygen is in the blood that is being returned to the right atrium. We call that the oxygen reserve. It's supposed to be 70 to 80, and we like it to be greater than 75. That's on people who are well. They're not ill. We call that their reserve. On people who are ill, if that drops down into the 60s or the 50s, that is called increasing the oxygen demand and oxygen consumption. That means there's more work. The more work there is, the more oxygen demand, the more oxygen consumption, which you learned with MI. So we may need to schedule lots of rest periods in between physical activity with these people, because the more we do with them physically, like turning them, bathing them, suctioning them, increases workload, which then increases oxygen demand, and it increases oxygen need, and then we don't have the supply because they're already dropping. If it's supposed to be at 70 minimum, and they only have 50 to start with, and you turn them, and it drops to like 42, that means your patient's not doing well. Stop what you're doing. They're not even half of what they started out of what should be normal. This is a bad thing. So if you have any other questions about cardiogenic shock, intra-aortic balloon pumps, or mixed venous oxygenation or saturated venous oxygenation, please do not hesitate to discuss that with your theory or clinical faculty. So now we're going to go into the last type of shock, and that's called distributive shock. And what that means is that's actually in relation to the vasculature or the blood vessels. But here's the issue. Distributive shocks are all vasodilatation shocks because we have so much dilatation that all the blood ends up down in the periphery, and we do not get a very good venous return back to the right atrium. Now, the three kinds of distributor shock that result in vasodilatation are neurogenic, anaphylactic, and septic. The first one is neurogenic shock. This is where you have vasodilatation because there's a loss of sympathetic innervation to the blood vessels. Typically, this is high in the thoracic or cervical spinal column. There's been permanent damage. It's a spinal cord injury. And below the injury, please remember there's no sympathetic control. In other words, the patient cannot move the legs, they can't move the stomach, they can't move anything that they have any control over. The only things that are working are the autonomic nervous system items, like the diaphragm, maybe, depends on how high or how low it is. The bladder, maybe, depending on how high or how low it is. But I will tell you that when the body, like say I didn't empty my bladder like I was supposed to, and now it's overextended, and I should be feeling bladder pain, telling me to go to the bathroom. The paralyzed patient will not feel that. But the warning signals from that part of the body do still get to the spinal cord, do still get to the brain. The problem is when it tries to get back down with the message of what to do about it. It doesn't happen. So the body keeps sending messages, okay, I'm still telling you I have this problem. What do you want me to do about it? And the brain says, I told you to do this, but that last part doesn't get all the way through. It gets blocked. That's because of that innervation issue. Okay, the second kind of shock is the anaphylactic shock. It and septic shock are vasodilatation resulting from some type of substance in the blood that actually causes the vasodilatation. And we're actually going to go into more detail in just a few moments. So again, just to clarify, neurogenic shock results from that loss or disruption of the sympathetic tone from a cervical thoracic spinal cord injury. Now, when somebody has neurogenic shock, yes, they have the hypotension. But the problem is the normal body response would be to have an increased heart rate to build that pressure back up. And your body would become cold and clammy because all the blood would be shunted to the core to try to help that cardiac output. But with neurogenic shock, those signals do not go all the way through. So yes, you get the low blood pressure, but you actually can get severe bradycardia. And you actually get warm, dry, or even hot and flushed skin tone because we're not getting anything but autonomic response and no sympathetic response action. This is the only one that the caveat is that there's no tachycardia, it's bradycardia. They're not cold and clammy, they're warm and dry. The one thing that is the same across all of these is low blood pressure. So even in neurogenic shock, you are going to volume resuscitate. You need to save their life before you can do anything else about it. So volume, volume, volume. Now, if volume is not working by itself, there may need to be some vasoconstrictors added. Remember, vasoconstrictors are those that tighten down on the blood vessels, causing SVR to go up. So those are vasopressin, which is the one that your body makes. Could be neosynephrine, could be levophed, could be dopamine. Okay? Now, anaphylactic shock is actually an allergic reaction that has invoked a life-threatening hypersensitivity response. Now, there's two ways for that response to have happened. Non-IgE means that I have never been exposed to that before. I get my very first exposure, and boom, I have a very severe life-threatening response. Okay, I've never had that. So like with bee stings, I've never been bee stung before. I get stung by a bee, and all of a sudden I'm swelling up. I can't breathe. My airway's closing off. That is a life-threatening response. That would be a non-IG, meaning you didn't have any disposing antibodies that have been created against that. The IgE anaphylaxis response is where you actually get stung. You don't have a response, but your body actually starts building antibodies. A couple of years later, you get stung again. Well, you already had some antibodies. Now your body's building up more antibodies, okay? And like about the third or the fourth time you get stung, that's when your body has this severe life-threatening response because you have built up your antibodies and it causes this response. So one, there's no antibodies, you get stung, it's a full-blown response. The other one, you have to get a built-up amount of it for you to have that kind of response. Now, how do we treat this? Well, we have to treat this based on what's going on with the patient, okay? So white blood cells actually secrete chemical mediators that cause the systemic vasodilatation. That's because it wants to open up the vasculature so the white blood cells can be rushed to the point of entry, like ambulances being rushed to a trauma, right? So if we dilate that or open up the freeway, they can get there faster. Now, this actually can increase capillary permeability, meaning fluid and other things can cross the cell membrane much more easier, meaning the guard who's at the door is distracted and he's paying attention to what's going on rather than doing his job of who can and can't get in and out of that cell, okay? Bronchoconstriction is just exactly what it says. This is constriction of the bronchial tree. Coronary vasoconstriction, that is constriction of the coronary arteries. And then, of course, urticaria. Those are the kinds of things that you're going to see happen with anaphylactic shock. Bronchoconstriction, you stop breathing. Coronary vasoconstriction, you get a heart attack. Urticaria, you scratch yourself to death, right? So when we get this arterial vasodilatation, this causes a maldistribution. In other words, blood volume is distributed in varying amounts in various areas of the body. And we do not get good actually return because we also have venous vasodilatation with this. Therefore, we don't get a preload. We have a decreased SVR, but we don't have preload to counteract that because even the venous system is dilated. That results in a cardiac output decrease. Again, I talked about that capillary permeability. Apparently, I think it's important because I put it on here twice. Now, if this continues on for even a short period of time, the circulatory system will collapse, or your vasoconstriction will occur within the minutes to hours, and that will actually cause respiratory arrest. So either I get circulatory collapse or I get respiratory arrest if I don't address these, okay? So these are the things you're going to see with anaphylaxis. I think you learned a lot of these in med-surg, so I'm just going to go over them really quickly. Generalized erythemia, urticaria pruritus, anxiety and restlessness. We're going to have chest tightness, dyspnea and wheezing. We're going to have vasoconstriction, and we're going to have vasoconstriction with stridor. That is why we're having tightness in the chest, right? We can have laryngeal edema closing off the larynx area. We can have angioedema in the neck airway, and we can have hypotension. Well, if it's a shock, you've got to have hypotension, right? So what kind of assessment do you want to do specifically for this kind of patient? Well, do they have a history of any allergies? we use those allergies to avoid the known allergen, and that's prevention. So prevention of anaphylactic shock is the best way to take care of it. But what about the one that you are not predisposed an allergy to, right? What about that non-IgE type of anaphylactic reaction? This can result in that anaphylactic shock because you don't know that predisposing factor and you don't recognize that you are having an anaphylactic reaction. You can go far enough into this that you turn into a shock state. How do you manage them? Well, if it's a bee sting, you want to remove the stinger, but you also want to make sure that you remove the sting sac, okay? Don't leave it in there, allowing it to keep pumping fluid in there. The other thing is if it's a peanut allergy and they've inhaled peanut dust, you're not going to be able to remove that offending antigen unless they do a bronchial wash, okay? So if it's possible, remove whatever the allergen antigen is. You also need to reverse the effects of the chemical mediators. Remember those cytokines? Remember those cytokines are being released so that it dilates the vasculature so that the white blood cells can rush to the rescue, right? But that's not always good for the body. So we have to actually restore adequate tissue perfusion. Well, if we're in a hypotensive state, we need to do fluid resuscitation, keep them alive, until we can restore adequate tissue perfusion and oxygenation. One of the ways we can do that, epinephrine. We can also give antihistamines. We can do corticosteroids and bronchodilators. Please keep in mind, if we give the bronchodilator first, we get the most bronchial dilatation that we can at that time to get maximum corticosteroid absorption at that time, okay? Now, when we have this kind of anaphylactic shock and we have this kind of response, mechanical ventilation is usually a requirement. If there's an oxygen tissue perfusion mismatch, then it's usually because we have both a perfusion in vasculature and a perfusion in oxygenation issues. So intubate and mechanical ventilate until the patient is able to recover. Now we also have to use vasoconstrictors and positive inotrope agents to help us with the SVR, right? We need to make sure that we're balancing the strength, the constriction of the vasculature, and we don't want over-dilatation of the venous system because we do want that return to come back to the heart to continue the cycle. We need to have it so that we can push it forward. Now, the last distributive shock that we're going to talk about is septic shock. Septic shock is a very complex, interactive system where invading microbes or microorganisms and the immune system, the inflammatory system, and the coagulation system all start interacting together, right? So cytokines are released. Those pro-inflammation kind of stuff. So we have dilatation happening, right? The white cells are being rushed to the rescue. But with septic shock, you also have the immune response and your coag system's response have activation. We again have increased vascular and capillary permeability because of the vasodilatation. But please remember that the body becomes out of control in that inflammatory response because not only are we releasing anti-inflammatory cytokines, we're also producing and releasing pro-inflammatory response chemicals, mediators, okay? So this makes an over-the-top or completely out of control inflammatory response. So this is like huge in comparison to any of the other shocks. We can get cardiovascular, pulmonary, and hematological alterations because of these changes. What you see on the screen right now is the pathophysiology map of septic shock through the central nervous system. It's kind of busy, but if you go one arrow at a time to a box and then follow it, it will make sense. Please recognize that whatever happens in this, you're invaded with a microorganism, and it will result in decreased tissue perfusion and impaired cellular metabolism, which we said that's shock, right? Okay, so how do we get septic shock? Well, we start out with SIRS, and SIRS is the Systemic Inflammatory Response System, okay? And that's the response to something invading. Now, we also have something, actually SIRS can be the Systemic Inflammatory Response Syndrome, which is where we actually are stepping up the activity because it's a known infection. We have a microorganism and we know it's an infection, and so now we have a higher response to that known infection. We get more vasodilatation, we get more cytokine release, we get more white blood cells coming to the rescue, okay? This moves you into sepsis. This is a known infection, but if it's sepsis, it's a known infection in the blood, okay? Sepsis means it is a known infection in the bloodstream. Now, the slide that you see now says that you have to see manifested 2 or more of the conditions that follow from the result of the infection to say that it's sepsis, right? So a temperature greater than 100.4 or less than 96.8. Sometimes you'll hear people talking about this as hot and cold sepsis, okay? A heart rate greater than 90. Yes, heart rate greater than 90 is not an abnormal unless you can combine it with one other component on this slide, and then you have a known infection, and then you have to consider sepsis. And you need to run blood cultures to either confirm or deny it. If you have a respiratory rate greater than 20 minutes a minute, or an arterial CO2 less than 32. So what that means is the higher breathing rate is blowing off more CO2. Well, that means the body's trying to correct some acidosis that we may or may not know about, which is typically resulting from sepsis. And of course, the white blood cell counts are going to be rising and going to the rescue. But one of the things is you're going to see white cell counts that are way greater than 12,000. The opposite of that is you can see an immunosuppressed response of a white cell count less than 4,000. Okay? If you have the higher white cell levels, eventually you will see immature forms of white blood cells, like more than 10% of them, to show up. And those are called bands, right? And I affiliate that to like when people go to war. All the wars you've ever learned about in history, they always took the able-bodied men, and when that gets depleted, then they go back to the community and they start bringing in the retired people that who've been in the service before. They bring them back in, and you don't necessarily have to not have an ulcer and all those kinds of things. And so when that gets depleted, then they start getting the younger men, the teenagers in. When that gets depleted, then they start getting the even younger kids, like 9, 10, 11, right? Well, that's exactly what's happened in this war. White blood cells, they're going to go to war. They're going to take care of it. They get depleted. Then they get the younger ones and the younger ones and the younger ones. And so you get 10% immature bands. Those are the youngest. Now remember, you have to have 2 or more on that slide for you to meet the sepsis criteria, and then that will ask you, or in your brain, it should trigger that you should suspect sepsis, infection in the blood, and the only way to prove that is by blood cultures, okay? So when you're looking at your patient, you can see manifestations of early mental status changes, okay? You'll see that increased respiratory rate, right, 20 or above. And again, they may be hot or they may be cold. You're going to want some lab studies, not only your blood cultures, but you want to see what your CBC is. You want to watch those white counts. You want to know what your basic metabolic panel is, because you want to know what your potassium, your mag, your BUN, and creatinine are. You're going to want to know what your lactate levels are, because you're looking for acidosis. Now, a lot of times these patients end up on the ventilator. And if that's the case, you can actually put them on an end-tidal CO2 monitor, which is a little device that goes between the endotracheal tube and the ventilator tubing. It is connected to the monitor just like a PA cath, an ART line, or CVP is. And it gives you a waveform, and it tells you what the end-tidal CO2 level is for every breath that's exhaled. You want to continue to monitor that, because if we start getting less than 32, we're blowing off too much. These people are usually sick enough that they put a pulmonary artery catheter in. So we're looking for PA, systolic and diastolic, wedge, RA, and CVP readings to help us determine what's going on. The one new thing that we're going to be utilizing is that mixed venous oxygenation, SVO2 reading. And again, theirs is not going to be anywhere near 70. It's going to be in the 60s, even in the 50s, and that's not good. And the more you move them, the more that will stop. So you have to give them periods of rest. You have to stage their care in short periods. Now, you will get CT scans, you'll get chest x-rays, you'll get abdominal x-rays, you'll get several other things, just like you would with any other patient. But these beginning components, remember their mental status, that respiratory rate, the heart rate, and then the hyper or hypothermia, and the white cell count. Those are significant, and paying attention to SVO2. Okay, so how do you manage sepsis patient when they're in shock? Okay, so this is the one and only time that you will ever see volume repletion, volume resuscitation second. I will tell you, we have to work on the identification and treatment costs before we can figure out that this sepsis. So, for the purpose of prioritization, it is identify and treat the cause. If you are in an environment where there's more than one person to help you out, then you have one person drawing the blood cultures while another person is getting the IV going and getting the IV fluid resuscitation going, okay? Because if you cannot fluid resuscitate them and you cannot get their blood pressure up enough to save their life, it won't matter what was the cause, because they'll be dead, all right? Mechanical ventilation is always a situation of consideration when you have a septic patient, especially septic shock, because it takes a long time to recover from septic shock, and it is only supportive. Your care and your treatment is supportive, other than the antibiotic therapy. You also want to maintain cardiac output by volume resuscitation. One of the things that's really significant with sepsis is the fact that we actually have severe coagulopathy. And one of the more significant ones is DIC. Please remember that with sepsis, you get all the fibrinogen used up at the beginning in the initial stages, making all these little bitty tiny clots, and then they micro shower all over the body, right? But then, when that's all used up, then your body starts, you see your patient start freely bleeding, oozing blood kind of quickly from every puncture wound, every open sore, every orifice from their body. That's because all that fibrinogen was used up, and now there's no more to help the clot. So that's what DIC is. Remember that, because sepsis patients, when they're in septic shock, we have a super high mortality rate. But if they get DIC, their mortality rate's like 98% now. It's just not looking pretty. And of course, if we are able to maintain life and sustain them and until the antibiotic works, then we have to consider nutritional support for these patients. And it's just like all the other nutritional support. We want to add protein for healing, but we add a lot of carbohydrates so that the body does not utilize the protein for energy. So they'll use the carbohydrates for energy and the protein for healing. Now, we talked about how shock states result in hypoperfusion. We have a tissue perfusion problem. Okay, so if I have a multi-organ system failure, the pathophysiology is the same as it is with sepsis because it is a progressive problem, just like SIRS and into sepsis is progressive. What happens is the perfusion at the endothelial cell level, okay, the endothelial is the inner lining of any kind of organ that you have. At the cellular level, that becomes injured. Inflammatory mediators are released. This causes a hemostasis imbalance. And hemostasis, remember, is your health balance. All right? So these mediators, or cytokines, cause this imbalance. We actually start getting microcirculatory collapse, which you heard me talk about that before. And if you get enough collapse, you actually have microcirculatory failure. Now, that means there's no oxygen getting through there. Now we actually get problems because we have had these micro clots that have been thrown out to the microcirculatory, and so we have these causing the injuries, right? They don't get the oxygen past those microclots, resulting in hypoxemia, resulting in further damage of the tissue because it dies, right? And so that actually contributes to multi-organ system failure, multi-organ system dysfunctional. Okay, you can see it, multi-organ system failure, okay? Or you will see this as multi-organ dysfunction syndrome. Either way, you have more than one system that is failing or not working right, okay? So, typically the very first organs that will manifest actual visual signs of dysfunction are your lungs and your kidneys, right? Your lungs, we talk about ventilating patients, right? Acute respiratory failure. And then when your kidneys, when the MAP hits less than 65, you now have renal dysfunction, right? You're not perfusing the kidney, and you can get renal failure, right? Okay. So again, you want to identify the inflammatory response. Look at the signs and symptoms. And then pay attention. Is it already moving into organ failure? If so, you need to know how bad. And there's a lot of different kind of scoring systems or assessment systems out there. But I will tell you the one that is most used is called the Sepsis-Related Organ Failure Assessment, SOFA. I do need you to remember this particular assessment of failure. Okay, this assessment of failure is the one that is most used, and it is the one that we will talk about on your exam. And I will go back and say again, treatment of septic shock, sepsis, septic shock, and MOD is 100% supportive, and it's directed towards whatever specific organ is failing until we can get them back into hemostasis. Okay? There's not much more you can do, which is why there's such a high mortality rate. So our biggest chance of winning that battle is to prevent it from starting, okay? Prevention is the only way to win this battle. So if you have any questions, again, please do not hesitate to reach out to any of your faculty. Again, this is Professor T.J. Land with Nursing 421, Transition to Practice, and this has been your course content clinic on vigilance and all things shock and MOT. Thank you, and I hope we have been able to answer several of your questions.